David.
Yes.
Figure out this word problem, okay?
Oh boy. Okay, here we go.
Okay, I got my friend Peggy. All
Okay,
right.
Peggy.
Peggy's a baker.
Cool.
She bakes all kinds of pies.
I love pie.
All kinds of goodies all day long. Apple pies, cherry pies.
Give me some apple pie.
Okay. On Monday, Wednesday, and Friday, she bakes apple pies.
Apple pie, Monday, Wednesday, Friday.
Yes.
Okay.
On Tuesdays and Thursdays, she bakes cherry pies.
Cherry pie, Tuesdays and Thursdays.
Mm-hmm. If she bakes 50 pies a day,
50 a day.
how many more apple pies does Peggy bake than cherry pies in a week?
Okay, so Monday, Wednesday, Friday is apple pie 50. So that's 150 apple pies. And then cherry pies Tuesday. So that's 100 cherry pies. So Peggy's baking 50 more apple pies than cherry pies a week.
Very good.
Yes.
You got that. Okay. How many steps did it take for you to figure out the answer to that problem?
I don't know, at least like 4 or 5. I mean, with all of those different things that were going on.
Right. So, I mean, you had a couple different variables, right?
Yeah.
But for the most part, you had data to solve your problem.
Yeah, I did. No, you gave me the numbers, you gave me the dates, you gave me the types of pie.
Okay. So you are not my friend, Peggy, but now I'm going to make you a Glennon parent.
Okay.
Okay. So you are the parent of Johnny.
Okay.
All right. And imagine Johnny has multiple specialists, like, I don't know, 4, 5, 6, and they all have a role in Johnny's care, right?
Yeah.
So all his needs are met. They're all equally important.
Of course.
And each specialist has their own plan for Johnny.
Well,
right?
yeah.
So you're at home with Johnny one night, and Johnny's has some stuff going on. He's got some symptoms, couple different issues. And of course, you can't access all of Johnny's doctors all at one time. And no one doctor is really the quarterback, right? So how do you go about solving Johnny's problem?
I don't know if I can, because I'm not the one who's coordinating everything between all of those doctors. And do I even have all of the information necessary to make some sort of a judgment call?
Exactly. So this is a problem worth talking about, right?
Yeah.
So as medicine advances and we are, we have bigger numbers of survival in kids that are very complex. And
Which
those
is a
kids,
great thing.
Right. It's a beautiful thing. And these kids have, 4, 5, 6 or more ologists or specialists, kids living at home who are dependent on all kinds of technology, have all kinds of medications going on, really complicated. And when there's no quarterback, you have to advocate for your child. And that's a very scary and vulnerable thing. So I'm going to kind of make an analogy to, I like the gym, I like working out.
Oh, of course you do.
Right. So you are more prone to injury if you don't have a strong core.
Oh, sure.
Right. So if you build up and strengthen your core, you can potentially do lots of things. You can decrease pain. You can, improve your balance, increase your stability, prevent injury, perform better, all of that. So if these families, hypothetically, had a strong core, right? If they had that quarterback, that might make life every day a little bit easier.
Well,
right?
I feel like it would give them a strong foundation, more than just a couple of legs to stand on.
Right. So about 10 years ago, in 2014-ish, a couple of our physician rock stars were thinking about this, right? And they were thinking, this needs to be addressed. They designed and advocated what was the first program designed for children with medical complexity in the St. Louis region. And we are going to have them here today.
I'm so excited about this because, you and I have been here for a long time, and we've met a lot of families over the years who have benefited from the complex care team, and just seeing and hearing from them how much of a game changer this group of people is to their care and access at Cardinal Glennon.
Agreed. Which is why this is going to be our first 2-part podcast.
What?
I know, right? There's a lot to talk about. So it's probably best, I think we all agreed, that we do this in 2 portions, right? So we're going to do this in two parts. So we are going to talk to the two co-founders of the Complex Medical Care Program, Dr. Aline Tanios and Dr. Kurt Sobush.
They're two rock stars.
Right. So we're going to talk to them and kind of learn about their passion for working with children who have medical conditions and kind of hear about what the vision was and the objectives and the launch and the first years of the program. And then for part 2 of the podcast, we are going to bring the Watson family to the living room couch here and talk to them and their current complex medical care program physician, Dr. Michael Smiley. And that will kind of, in part 1 and part 2, give us the full circle perspective about this program and how it impacts quality of life for these families living with medical complexity.
This is going to be so awesome. I know we're making it a little complicated with this, but that's how healthcare can be. And I'm so excited to sit down and chat with all of them.
Yeah, it's going to be fun. Let's go. Welcome, guys. How you doing?
This is great. We're happy to be here.
So happy to be here.
Y'all
We're
are
so
so
glad
fancy.
you joined us.
That's what
Thank
I
you,
said
thank
when they
you.
walked in. I said they're so fancy.
I know. I did not get the jacket memo.
I know. I'm used to seeing y'all in scrubs and things, and you brought your fancy today. We appreciate you.
We like to fake professionalism once in a while.
We
Yeah,
feel
so.
special.
Just for you today.
Sometimes it comes in handy.
Well, joining us today, we have a power duo. We have Dr. Kurt Sobush, who is a board-certified pediatric pulmonologist and medical director of the Complex Care Program. And we have Dr. Aline Tanios, division chief for pediatric hospital medicine and associate director of the Pediatric Residency Program. Y'all have much more fancy titles than me.
Well, we do. But we like these titles.
We like these titles. That's good. I'm happy that you do. So I would like to start with the two of you each sharing a little bit about yourselves, kind of like how long have you been at Glennon and what spurred each of your interests or passion for caring for medically complex patients. So y'all get to decide who starts first.
Why don't you start? Yes, you.
Should we rock,
so
paper, scissors
polite.
You
for it?
seem to want to go about this.
No,
yeah.
you go first.
So I arrived at Cardinal Glennon after training at Cardinal Glennon years back, but came back as faculty in 2011. And I've been a pediatric pulmonologist in that role. And when I initially came back, I was doing a lot of basic science laboratory work. And then my shift to clinical work was really more in the coming years after that. And so my interest in complex care came about because in my pediatric pulmonary clinical role, I see the whole gamut of pulmonary diseases, asthma, cystic fibrosis, you name it. But where they needed me the most was in chronic ventilator management. And so I helped with managing a number of patients that had those issues. And in doing so, when I dealt with all their respiratory complexity, I picked up the interest in just every other non-respiratory medical complexity that oftentimes patients and their families shared with me. So it became a natural fit.
Okay. How about you?
So I joined Glennon in 2014. So this is my year number 10. And I'm a pediatric hospitalist. So I care for children who are hospitalized, who are in the hospital. And a lot of these kids have more medical complexity. And I started having a passion for this population back, like probably when I graduated, and I was put in that role at another institution. Slowly but steadily, at the beginning, it was very intimidating because you fear the unknown. And these kids were difficult to challenge with their medical complexity. However, the reward received when you care for them and the bond you develop with their families alleviated that anxiety and made me more passionate about them. So when I joined in 2014, Dr. Sobush and I got together, and the rest is history.
I want to jump in here because I'm the only one on this podcast that's not a medical person. So I'm very, very vocal and admittant of that. I'm just glad to be a part of the conversation. But can you talk to the people kind of like me to talk about what what defines a patient as being medically complex? You know, if there's a certain set of criteria, what types of patients would actually benefit from having a complex care program at the hospital?
Sure. So in the past, historically, children with medical complexity was a term that's probably come about in the last 20 years, just as a concept. And initially it was brought about by children that, you know, maybe 1% of the population would take on somewhere between a third to a half of the healthcare cost of the system and the hospital days and the hospital costs. So there's a term that got used that I'm not totally fond of, but they were deemed super utilizers. They're these small numbers of patients that really took on a lot of not only cost, but care needs of resources and other things along the hospital lines. That has changed a little bit because that all defined kind of what they used in the system, and it really didn't define anything intrinsically with those children. And so then there was a push towards, how do we define these kids? Is it by number of diagnoses? Is it by number of care providers that they see? Is it by just whether or not they have medical technology that they use? And so that became sort of a trend in terms of how you defined it. But there hasn't been a unifying diagnosis of how you call someone a child with medical complexity. So there's only recently been a new article that's come out in pediatrics that has defined it by 38 domains. So it's pretty extensive. But the nice thing about that is that it includes things like family needs. So whereas before it was always things related to their diagnoses, their use of the healthcare system, now it's more based also on whether or not there's respite available for families at home, whether they have financial strain because of the taking care of their child, whether it has to do with something along the lines of the school nurses or the home healthcare nurses that are available at home. So they've taken a lot more of the social determinants that really factor into medical complexity and things that families face.
So how about some examples, like children with blah, 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 children with blah, 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 like boil it down for us. Because kind of like David, I'm thinking there's people listening that don't really understand what kind of kids we're talking about.
Sure. So let's say you have a premature baby who is born with heart disease, and then they had seizure, and they had intracranial bleed, and they have difficulty swallowing and eating. Therefore, they're going to need an equipment in order to feed them, like a G button, that's what we call, or gastrostomy. And then they're also having lung disease, whether it's asthma or something else. So that's already like a constellation of so many medical problems, not just one, not two, so many, which will require seeing so many specialists. And that's a lot. So this is where the complexity word comes from. So for example, if I have a kid who has asthma and eczema and seasonal allergies, usually these fall, we call them under a triad. Usually these falls under like the same umbrella. They are complex, but not as complex as the one I just mentioned earlier. So this is like an example. Now you also have another common example that really fill our clinic, or the program, which is the patient who are born with a genetic condition. And these genetic condition or syndromes, they have a long list, like you start from head to toe. And it's really hard to put them in one category. Therefore, they are called complex.
So you're seeing this in the hospital setting. You're seeing this with a lot of your ventilator dependent kids. And so I'm trying to imagine, you said, I talked with Kurt one day and the rest is history. So I'm trying to envision this. So y'all know each other, you cross paths in the hospital. So you're going about your work, you're seeing this need independently, you're seeing it multiply over the years, right? There's more and more and more of these kids. So I'm trying to figure out, are you like having lunch one day, eating Snackers in the cafeteria, and you strike up a conversation and say, hey, we could do better. Like we need to do better with these families. Like, how did this happen? Like before the program hits the world, right? Was there just some repeated conversations? Did y'all like get this big plan in place before you went to administration? Like, what was the very beginning? Tell me from conversation to like, hey, we're going to actually walk in the door and talk to somebody about making this a thing. How did that happen?
Well, I mean, I think Dr. Tanios and I met probably first time just in some resident education training or something along those lines. And we hit it off there. And in that, then subsequently, as we were working through our own individual career paths and whatnot, and we were both reflecting on this recently, how Dr. Bob Wilmot, who was our pediatric chair, he was really a visionary and has developed so many programs for Cardinal Glennon and has unfortunately just recently passed. And so we've been kind of reminiscing about him a bit, but he was able to see that we had shared interests. And so from that standpoint, whereas we were having, more friendly kind of at least just kind of getting to know each other types of moments, this became then more of a professional one where we were sitting in his office, we were working out what the program may look like. Fortunately, Aline has had some experience at Arkansas Children's Hospital where she was part of their complex care program, where that was one of the original programs in the country. And so there was that added perspective that she was able to provide. And I was like thrilled because I think that it was something where we knew that the gap was there. We knew that it was something that had to pull together. And so with the help of our department chair then, and our interests that were shared, we were able to take it to hospital administration and justify the need, justify what would be really incredible in terms of something that is a little bit unheard of in the healthcare system. This is a program that was intended to limit patients being in the hospital, to limit ER utilization, to limit certain things that would be unnecessary types of visits, which, it's the sort of thing that could possibly bring money to a healthcare system. But we at Glennon, because of the mission that was driven, it was something that they decided this is important because this keeps families out of hospital. This keeps families in coordinating the care that is much more convenient for them and efficient for them. And so from that standpoint, it just took off from there. And so it took some convincing, but I think that it really bought into at least the mission of our program, because I think that it was felt to be what was right for the kids and their families.
So, excuse me, along these lines, I remember when I joined Glennon, I did share with Dr. Wilmot that, I have a passion for children with medical complexity, and at some point I would be interested in working toward the program or something like that. So, I don't know, like maybe 6 months later, he sent me an email and to tell me that, hey, how about you and Kurt start working? And I'm like, wait a second. I thought this is like a long-term plan, not a 6 months plan. But as Kurt mentioned, like the stars aligned between the unconditional support by Dr. Wilmot, as well as the high drive that both Kurt and I had. And like this, this is a passion for us and this patient population. And the hospital administration, we literally hit the road immediately. And within a span of less than a year with prep, and the program is up and running at full speed. And I will say it was one of the strongest programs to hit the road in this way, in this format, with that structure.
So this was able to take off in less than a year's time.
Correct.
Once the idea kind of got proposed to administration.
Yes.
Sure. So what kind of prep did it take? I mean, you can't. I'm assuming, again, I'm medically dumb, but you can't just say, "Oh, well, I mean, I'm sure we have some kiddos that would benefit from this. Let's just open up our doors and start it." What did that process to get the whole thing set up? And I mean, I'm assuming that both of you still had to maintain your at then current roles in the hospital, and this became a new passion project on top of your jobs, kind of like what we're doing here with the podcast, right,
yeah,
Laura?
Kind of like. Mm-hmm.
What did that kind of look like to really get it off the ground for you all?
So I think it was multifactorial. Part of it is, so what we brought to the table was our clinical expertise and our vision. Now, there was obviously so many details, some required some data collection, see what kind of population we have. Will that program be serving enough patients who would be worth building a program, who would be on that program. Again, designing the whole foundation was key. We did end up also visiting two main programs across the nation. One was Arkansas Children's, and the other one was Milwaukee. And just to go through some of their, because every program is different. And we ended up building our own that is also different than other programs. What else?
Well, I mean, I think part of what made those site visits so effective was that we took with us nursing leadership, we took social work leadership, we took hospital administration leadership with us. And so from that standpoint, it was as though we were able to think through all the relevant parts of starting a program, where truthfully, I was fairly junior in terms of my faculty status at that time, and I didn't really have great insight into program development. And so from that standpoint, it was good to have that support.
I love that you call it site visit. I call it a field trip.
I'm
a little basic, but field trip.
They have to call it fancy something for when it's medical.
Yeah,
Yes.
It did
Very
end up
fancy.
actually being like a nice field trip. We did have fun.
I love field trips.
Yes.
And you do have a mission statement for your program, which I love. Not every program has one, but if I can read it, it says, the SSM Health Cardinal Glennon Children's Hospital Complex Medical Care Program will strengthen the voice of a medically fragile population in need of substantial medical and psychosocial care by further respecting their human spirit, appreciating all factors that can affect a person's state of health, and embracing them in a community of dedicated healthcare providers. I love that. So you have this mission statement. You already know the need was huge, but I'm pretty certain as a fledgling program, you anticipated some operational limits per se. So how many patients did you think you could handle? And who are the other team players on the quarterback team besides the two of you?
Well, I think that when we developed the business plan as it related to this program, it was maybe we'd be adding 50 to 100 patients a year or so, somewhere in that ballpark. And we wanted to make sure that we hired appropriately for a certain patient population. So when we first started out, we really made it a very strict criteria of who would be eligible for the program, because we didn't know if we would just get an onslaught of patients that were interested in our progress. And so we didn't want to be run completely to the grindstone with regards to just being tapped out with our resources at hand. And so from that standpoint, we set it up so that we would grow at about 50 to 100 patients a year. And we've met that, exceeded that. We've gotten to a point where now we're at about 380 patients, but we've graduated many patients. So from that standpoint, it's been very, very fulfilling from that standpoint. So in terms of the key people that were involved with the program's development, aside from us, Dr. Broom was one of our also initial physicians who was involved with that, who was quite influential as it relates to that. Mary Howell was a nursing leader who was involved with that, who was with me on the pulmonary side of things prior to that changeover for her. Erin Hooper was a nurse practitioner who was a nurse at that time, so she acquired that at one point. And then we had some of the staffing of people like Sean Dryden, who was previously here at Cardinal Glennon, join us, and some other folks around.
Yes, and we had Katie Carter as our dietitian. She was with genetics, and then she moved full-time with us. We had Whitney Nolden, who is our patient coordinator. She's literally the image of our complex care program. And then we have Juanita, who became our nurse navigator. And then things start and we had Jen Hawkins, who is our respiratory therapist, and Jen, our social worker. So the thing is that we had, we call them a core group. Every patient would have a faculty, and then nurse, a dietitian, a social worker. And then if these patients have technology, they are technology dependent, like vent or trach dependent, then we will pull our respiratory therapist, plus minus, obviously, the speech therapist, occupational therapist. But these folks that we mentioned were really the core group when we launched the program.
Yeah, it's kind of in the mission statement. We wanted a dedicated group of committed providers that we weren't going to just expand to everyone in the hospital, because I think then you lose a little bit of that coordination, and you lose a little bit of those that can actually focus some of the care of trying to gather all the information that's coming from many different places. And so from that standpoint, we wanted to keep it somewhat core, but also people with enough experience, at least at different parts of the hospital, the outpatient side or the community, that could really influence some of those connections.
So you saw this growth. I mean, like you were planning on getting about 50 per year, but then it ended up being much more than that. So how affirming was that for both of your passions to just see this need of care for a program that you just started to, then people were coming to this because they needed this and it was something that they were craving?
Well, I think it's humbling, because I think that suggests that the need is out there. And so from that standpoint, I think we recognized that, both Dr. Tanios and myself early on, but I don't think we knew exactly how much. We had projections that some of our data gurus here at Cardinal Glennon were able to somewhat pick up for us in terms of knowing exactly what's out there in the community. But when we started to see which patients were actually coming to us and where things were falling a little bit short and where we could really help, it was the sort of thing that, yeah, we need to take on more of this. And so from that standpoint, it was easy then to help justify pulling on more staff resources to help our team to develop the program further, to find adequate space for us to really provide the services that were needed, and take the leadership from there.
So let's get into the work, shall we? Like, what do you actually do for these families? Because it's a clinic.
Correct.
Like an umbrella of services, right? But so they're coming to the clinic, but a lot of the work is behind the scenes. So like, what is the actual work? Like, I'm trying to paint the picture for people who don't understand what's happening.
Sure.
To have you. Like, does that make sense?
Oh, yeah,
So,
yeah, absolutely.
So explain that.
So let's say Laura is coming. Okay, and
I could use you. I'm not gonna lie, for my life. It's complex. So
You can self-refer.
I'm
let's
coming.
say little
Coming next
Laura.
week.
So when these patients are referred to us, they go through certain criteria depending on what the program has designed to have. Because again, as Kurt mentioned, we made some strict criteria just because we weren't able to staff all of these patients at the beginning. So initially the criteria were that you have to be followed by 5 specialists. You are 10 years and younger, and followed by specialists, but do not fall under, let's say, another multi-specialty program at Glennon. So when the patients are referred and before clinic time, there's a lot of work, as you mentioned, to be done. It's literally a lot of homework before you go to your test. So let's say the clinic visit is the test. Before they come in, you review all their notes, all the specialists that they have seen, why they're referred here. Are they referred for 1, 2, 3, 4, 5 problems? Or is there one that is more significant to handle, yet we have to address all the others? Collect all the information, build what we called an individual health plan. And I always like to call it the live medical passport. So each patient will have this individual health plan that lists all their medical problems, who are they followed by, the latest imaging results, the latest surgeries. So let's say, I'm just going to talk about this real quick. That is a document that parents have all the time, is constantly updated by our staff, and that they can take anywhere they are. So let's say if they are 2, 3, 4 hours away and something happened to their kid, they don't have to search everywhere to share the medical information with the urgent care or the emergency medicine. So prepping that individual health plan, reviewing what needs to be done, and then patients are here. When they're there, you go over all of this, especially the first visit. The first visit is lengthy. Part of it is because you have to, meet the family, build a relationship, address their needs, listen to them. You already met the patients on paper. That's easy. You need to see the dynamics in the room, read some body language, see exactly how does this patient in person match with this patient on paper. So that takes not just one person. And this is why having that core group, seeing that patient at that visit, all of us, let's say, as I mentioned, physician, nurses, dietitian, and social worker, each one of us can give their own perspective. Then we wrap up and we come up with an action plan that is mutually agreed with by the family. And we will we always say that this is a family-centered clinic, that the patient is in the middle, and then all of us are around that patient to add each perspective, each expertise, whatever you want to call it. But at the end of the day, it's what's best for this patient.
Yeah, it's a shared plan. And in the pre-work for so many of these clinics, there's 90 minutes that are given for that first clinic visit, which is well beyond, I think, what we typically set for most outpatient, specialty visits or primary care visits or things, because we want to make sure that we're all talking as a team, not only in the room, but also afterwards. And so, but the pre-work that goes into it, it's probably about 10 hours of team time that goes into a 90-minute visit that goes on before everything. So all the data collection, all the note reading, all of the, a lot of these kids have medical care needs that are being served at health systems outside of SSM. And so it's partly collecting what might be going on at a hospital in Philadelphia or some other things that may be going on as it relates to their care. So that takes added work. And then that development of the individualized healthcare plan that Dr. Tanios was referring to also takes a fair amount of work, but we work on that somewhat in the clinic day. We do that refining on the week after, and we try to get that out to families so that they have that living, breathing document of something that can help out if they have an urgent need or other things, that they're not having to, for lack of a better term, regurgitate every piece of their medical backstory, which can be quite just stressful for families that go through that process, and having to do it over and over again is something that if you can have a document that has some of that there, that's ideal.
90 minutes seems like nothing. We will sit in here and record a podcast and listen to a family story and feel like we haven't even scratched the surface. So,
90 minutes flies.
Yeah. And I would think that they crave that. One of the key points, yes, is that you serve as I think I used this term earlier, the quarterback, right? Because they have 4, 5, 6, 7, 8, 10 ologists, right? And is the right hand talking to the left hand? And okay, complex Johnny, who's got a million different issues. Okay, he's at home and he's throwing up. Okay, well, who do I call?
Yeah.
Because I could call this one or that one or this one or that one. And is the goal kind of to have you steering the boat, so to speak? Each of those ologists still has their place and has the utmost importance to Johnny, right? But y'all make sure that Dr. X is talking to Dr. Y and that Dr. B is talking to Dr. C, and you kind of help the family drive the overall boat, yes?
Yes. Yes and no. Yes, because you do not want to replace the primary care physician for these patients.
Yes.
However, we have developed a great relationship with pediatricians in the community where this is also, they cannot devote 90 minutes of their day to, and they don't have the resources. Even if they want to, they can't. So we are, this is why for some patients we do have a sick plan. So they go by step 1, and that sick plan is developed by both the team and the family. So if this happened, then we use start 1, 2, 3, 4. However, if these warning signs start to pop, then you have to call 911 or whatever. Now, yes, they do call the complex care program, and then our nurses do an amazing job by screening, as well as triaging whether this issue can be, is it medical, is it surgical, do they need to be addressed emergently, or do they let's try this plan at home and see if it will work? Do we need to call in something for them? Do we do like a quick telehealth visit? So you try your best, as Kurt mentioned earlier, you really try your best to keep these children at home within their own environment, saving the family a 3-hour trip. I mean, this is not an easy trip. This is not like, yeah, let's get in the car and move. There's a lot of equipment to go with. There's wheelchairs, there's oxygen tank, there's the ventilator. I mean, so this is a lot. So you try to do what's best, but to do it safely.
Sure.
No, because you're also not covering 24 hours and weekends. So they still have to go to their primary care physician. Most of the time they end up actually in the emergency room.
I think it was really important that we did not replace the primary care providers as part of this program. And I always use this term because I'm from up north, I'm from Milwaukee, and I don't know how many people around this area know about skyways and how they work in a downtown area. And I always like to think of the ground level where all the streets are as the primary care providers. And then you've got the skyways that kind of bridge between the different buildings. So if it's treacherous traffic, weather, whatever else, you have easy ways of getting through to the different parts of the healthcare system or the different buildings in a city. And I think of the complex care team as a skyway. And the ground level, though, is you don't want to neglect that. Like that's so important for what's needed for the primary care providers. And so we want to collaborate with the primary care providers. We don't want to replace them. And so they oftentimes are the ones referring to us as opposed to families or specialty care providers, because we do want to offload some of that work that they have on those 15 to 30 minute visits that they're really only allotted to help care for their patients. And I know they put in more time than that, but we're here to build on that resource and give them added time and help out in those different ways.
I love that analogy. That is beautiful. And I guess another question to that is, how was this concept or this program perceived by the subspecialists? Like, to your point, you're not replacing the primary care. You're not replacing or trying to uproot any of the subspecialty efforts, but was this threatening in any way? Like, oh, they're going to be advising my patient to do this, and I really want my nails and all of that. Like, is it more of a threat, or is it more of a, oh, thank God, because this is complicated and thank you for taking, or was it some of both? Like, how was that in the beginning, or how is it now?
Well, I mean, I think change is scary for a lot of physicians who have their commitments to their patients, and that includes the nurses that work in those different settings and everybody else on the healthcare team. And so I think we wanted to make sure that we weren't coming in and providing them with a clinical care plan that was not in line with what a specialist may want to have in place. And so we've been very careful about those things that we can help with, those things that we should really be suggesting that they contact so-and-so as a provider, and we can help facilitate that communication. But on top of that, we have also recognized that there are certain services that don't have an ideal dedicated provider, like an outpatient pain service with Cardinal Glennon, which we've really provided a lot of support as it relates to that with our complex care program, because it's been difficult for a lot of our families to identify who that would be. And so from that standpoint, we've filled those gaps there. And so part of it is that, yes, we are very respectful of our specialists. We collaborate with them as well. We try to respect what things they're comfortable with us doing and those things that they would really prefer to keep to themselves. And if there are things that they prefer to keep to themselves, we share that with the family or primary care docs, that this is really the route you should be going, and we help bring those communications.
I mean, I agree. And then I will say we tried our best to stay in our lane. And then, however, with the impact that others have started seeing, we realized that we played a major role being the liaison between the specialist and the family. And the family value that, because they know that you have their back, but you're also you have easier access to all the specialists. And then we got some answers to them in a timely manner, consistently. And that made a huge difference. Yeah, at the beginning, this is something new.
Well, the specialists started seeing that there were more people able to show to their clinics as well, because we were able to coordinate clinic visits. We were, instead of having to go to Cardinal Glennon from 3 hours away 3 times a week. We were able to do it in one day, and that helps build up some of what might be needed for those specialists that are wanting to make sure, well, why aren't they here? Well, they were here 2 days ago. And so from that standpoint, they bought into that quickly.
Yeah, I feel like that's a big part, when I ask, like, what is the work that you're doing? So that coordination of care. So, how is that like for a family that, because prior to adoption by y'all, right? If I got so many clinics that are all on my now radar, like some people graduate and they don't have to see certain clinics so often anymore, or whatever. Yeah, but at least initially, especially for a lot of the preemie grads and things like that, they're seeing all their specialists a lot and frequently. So how do you do that? How do you lessen, I guess, the amount of visits or amount of travel
That's
here?
A great question. And I love that program, but I don't think we don't give enough credit for the people who do all the coordination of care behind the scene. So to coordinate, let's say 5 or sometimes 6 visits in one day, that's huge. I mean, you're talking about different clinics, different specialties, different location, for someone who's been driving maybe like 2 hours, 3 hours. So the family loved that. Now they get exhausted, yes. So
it's a long day.
They have to dedicate, but that's much better. And also it takes a toll on these children, putting them in car back and forth. So what usually happens is that we try, and when I say we, it's not me, it's the nurses and our care coordinator. What they do is they say, oh, you're due for an ENT follow-up and you're due for ophthalmology. Okay, they will end up scheduling, talking to the specialty nurses in these different clinics, and then they schedule the same day. They're coming to see us in a way that you're going from one room to another. That's a lot. But whether there's labs to be added, oh no, let's not bring you here for labs only. You're coming another week. Is it going to make any difference? No, we can wait another week. So between labs, counting imaging, MRI, x-rays, I don't know, you name it. Sometimes procedures. And we're talking only about the outpatient side. We've had many, many, many successful stories when some patients will need special procedures. Let's say ear tubes to be placed, tonsils to be removed, a G button to be placed, all in one surgery, like 2-3 hours.
Oh my goodness.
And then it's like you're checking one box after the other. So these patients get submitted the night before, are prepped. We are notified a week in advance that this patient is coming. Let's make sure that 1, 2, 3, and while they're here, they were due to see ophthalmology. Can you call ophthalmology so they can see them in the hospital? So you're checking literally so many boxes. However, I will say we are beyond grateful for everyone, for all the specialists. They will never say no. I mean, unless there's emergencies, but they never resist whenever there's a complex patient to come and adjust their schedule to meet the needs of that patient.
My mind is just blown at that because I can only imagine it's our term today, but the complexities of scheduling just one procedure in a hospital filled with hundreds of other patients. It's hard enough, Laura, in our office with just little old us trying to schedule 6 different people for one meeting. I can't imagine everything that it takes to schedule 6 different specialists for a single day for a visit for a family. I mean, that just absolutely blows my mind.
But like you said, part of that is leaving egos at the door and look at, you know what I mean, on the part of the subspecialist, right? And saying, no, this is what the right thing is to do. Yeah. But the other thing is how awesome, because Mrs. Smith, with no medical background and no ability to navigate hospital anything, doesn't know that, okay, the G button placement and the tonsils and the adenoids and the 4th and 5th procedure, she would have no clue that, oh yes, we could potentially do 3 out of the 4 in one procedure. Like she
one
wouldn't
sedation.
feel like she could even address that animal, right? She's never going to ask for that more than, I mean, some parents would, but many parents will not even say, well, I might just ask if one or two of these could be combined. Like chances are they're not going to advocate for that themselves because
not at the beginning.
Not at the beginning, but you teach them, right? Like that they deserve that.
Yes.
Like you deserve to think about that.
Absolutely.
And like that, right?
Absolutely. At the beginning when you were talking about the mission, there were several goals also from building this program. But one goal we forgot to mention is, yes, taking care of a patient as a whole. But when we say as a whole, as we mean as well, like the family, the siblings who are around, but it's also empowering the family to take a lead and to take to have a voice, because it is also intimidating and it's also like, I don't know, it's already overwhelming for them, and the medical field is already intimidating for anybody. So empowering families have also been a big part of our mission.
For sure. For sure. Let's talk about current. So you see this need and, you were saying, well, we didn't want to open the floodgates and, we got to do this, but we quickly saw like, oh, okay, there's a lot more. So how have we grown to meet that? In other words, like, it's not bringing money into the hospital, right? Like this isn't a money maker. So nobody's like super excited about adding staff to y'all, right? Like how did that happen? How did where we're at now get to be there? Was it just like you had evidence to support it, or like how did we get from fledgling program to where we're at now? Sure.
There's been some help with some grants for some of the earlier programs that were put out. And with that, there are staffing ratios that are felt to be needed for patients that have medical complexities. So it will say that for every 100 patients, you should have a one physician complex care provider that is providing that service. And so many will cover for social work, so many will cover for that. So that has been a little bit of a template that's somewhat grounded in what's been seen nationally. Whether or not that's easy to achieve or not, that's always a difficult ask. That said, I think that a lot of interest goes into what goes on behind the scenes. And I think that they know of our need for the 10 hours before a patient visit for that's being seen new. They know of the added hours of time that are needed per month between visits as it relates to our program. And so they factor that in as it relates to building our resources around that. So we built to having now, I believe, 13 at least staff that are parts of our program. And so that helps cover our 380 patients, and it serves us well. But we're always looking to add more, because I think that we're always kind of at that threshold of, all right, we're at that staffing limit. We're asking a social worker to take on, somewhere in the ballpark of 200 to 250 complex patients that can be quite draining. And so from that standpoint, we always want to have them active and working, and I think we take that on. But it's also with the notion in mind that it's not just the time spent there in the building; it's the time spent behind the scenes, and to try to help limit some of those untoward medical outcomes of being in the hospital without expectation, or having to go to the ER unexpectedly, or some of those types of things. So from that standpoint, we do our part to work on that. I think that aside from that, the ask of our program, we do help the hospital. I think we do help build, if a patient really requires a specialist that maybe that has floated under the radar, we find that for them and we pull them in. And so it's not as though it's all a negative gain for our program and the hospital and SSM and Cardinal Glennon. I think that we do help with that. So it's a sustainable program, and I think it's going to be around for a long, long time. But from that standpoint, it's something where you're right. It's not like we're doing this for pulling in funding or other things that. We're doing this because it's the right thing to do. And so much of the work is needed behind the scenes to be advocates for these families to build that and help the communication piece.
Yeah, it's not the glory.
Right.
you're not getting any Oscars for this. I mean, other than from the families, So I guess, how does that, I guess maybe if we can categorize and, we've spoken to some of it, but all the coordination of care, what is the direct benefit, I guess, I feel like we've kind of addressed the family, but to the hospital, like, no, it's not financial gain, but what is the gain from the hospital? Like what, you know what I mean?
There's fewer surprises. I think the kids are hopefully better since they have some chronicity to their disease. They're coming in at a better baseline. And so from that standpoint, and we're having more touch points with them, we're having a lot of interactions that are happening, be it phone call, be it in-person visits, be it something else, calls to their home health company. There's a lot of touch points that allow for that baseline to remain at a slightly higher level. And so from that standpoint, that's always great from our standpoint, because we try to limit those surprises, those unexpected ER visits, those other things that really get in the way of just, they're very disruptive to day-to-day care for these families. And so that's a big piece.
And there's also another piece that when you see these patients, you have time to address the patient as a whole, like I said, from head to toe, which means that you will be able also to refer patients to address different issues that have been going under the radar because they're not as acute. For example, this patient is having, I'm not sure if he's seeing, is he blind, not blind? Well, we were supposed to see the eye doctor, but, he got sick. So increasing that referral stream to our colleagues and specialists has also helped indirectly and directly the patients, as well as our specialists and the hospital in itself. So it's not always like a negative thing. It's fulfilling, and then it's also filling everyone's cup.
This is so bothersome to me. Like, I feel like we have more and more and more of these complex kids.
True.
And, we keep going back to this longer visit, this more tailored, less, I don't know, cookie cutter's not the word, but a more tailored, truly holistic appointment,
mm-hmm.
right? I feel like we're seeing more and more complex kids in whatever, the world, mm-hmm. in the hospital, like the numbers are just going up, 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 up. Is there a world that you can foresee that the typical appointment, be it a subspecialist, a primary care, there needs to be an acceptance that it's longer? Or because if it's not, or if that status quo doesn't change, I feel like more and more of our families need that tailored, like they need the sit down to go, okay, let's really take a look at this. Let's really get to the bottom of it. Because otherwise we're just churning and burning, right? And I don't know, like, do you foresee a need where this is going, I don't want to say this is going to become more normalized, like I hate
yes.
that. I hate that
More
we have children
standard.
who need this, right? But
yeah, eventually, yes. And I should say that some of the specialty visits are geared toward this approach too. Like
sure.
They are also multidisciplinary. So they spend enough time with these patients. Now they will address few things, but again, like I said, they don't have that luxury of time to address more than what they can afford during that time frame. But the goal to have more and more of these family-centered visits is crucial. But you have more kids, and you have limited space. There's only 24 hours per day. And then you try to do your best. Now, part of our complex patients, when they come for a follow-up visit, some of these visits are like very speedy, right. Because part of it is you've handled so much on the phone, you've handled some in my chart, you've talked to the families. So you're doing like more like the wrap up. Okay, we're doing 1, 2, 3, and you need like the physical exam in person then. But yes, usually the first visit is, I wouldn't call it burdensome, but overwhelming.
Well, kind of like you said before, some of your children have graduated.
Yes.
Right?
Yes.
And isn't that the goal, that you empower these families, teach these families
True.
that they
Yes.
evolve to a point where some of this they feel like they can
handle.
handle and ask for themselves.
Yeah.
Right?
And some of these kids actually, let's say they still have this condition or this syndrome, but they don't need all the action like they used to when they graduated from the NICU or the neonatal care unit. And then you can see, oh, you're not seeing this one, not this one, not this one. Okay, you can, and some family do not want to graduate. You offered, like, we're not going to kick them out, but some...
It's like cutting the cord.
No,
no, don't make me graduate.
Some feel like, and we always tell them, this is our number, this is, we will remain your people, but I'm just trying to save you a trip to visit us. Not that, we would love to see them, but just saving them an extra visit.
It's so true. Some families, I'm one, don't like to graduate.
Yeah.
Right. But so much of this it's also, the medical technology has allowed for us to have patients that are born younger with more medical conditions, that are sicker when they're at various stages of their life, that allow them to carry on. And from that standpoint, with that comes, the complexity along with that. And so from that standpoint, it's something where I wouldn't want kids to necessarily become less complex just in terms of our general society or other things along those lines, because I think what we're seeing is some of the beauty of those initial surgeons that perform that life-saving procedure at day of life 1, and that, all that comes from that afterwards, we're there to help out with everything else. So from that standpoint, I think that this population is growing because of all the wonderful things that we're able to do for some of these children very early on. And so from that standpoint, once we get to that point, then it becomes a matter of how can we prevent issues, because in pediatrics in particular, prevention is such a more efficient way of going about medical care, as opposed to, slapping a Band-Aid on everything that happens and then coming back to it again over and over again. So from that standpoint, we really strive for that. But it's a problem, but a good problem, at least in terms of some of the medical complexity that we see.
So you have 300 and, I'm sorry, what was your number
380
before?
or so.
380 or so enrolled in the program now. So we didn't really talk about demographics. So what are some of the bigger percentages of, where are all those kids at? Are a lot of them in Missouri, Illinois, several states? Are we seeing a whole lot of preemie grads? What are some of the key, I don't know, pieces of the pie that you can share?
I think the bulk they come from Missouri and Illinois. We do have some from other states along with that, a few patients, but the majority of our patients are under 5 years of age. I'd say probably somewhere in the ballpark of 70 to 75% of those patients. And that's largely because of those immediate needs in the neonatal time period, that they may have been born with prematurity or something else that was a life-limiting condition early on. And so we also, as Dr. Tanios was talking about, we were talking about some of the strict criteria of what brought into our program initially, and we've loosened that criteria as we've gained staff. And so, whereas before it was 10 years of age and younger, now it's under 16. And so we have slightly older patients coming into our population. And on top of that, we have those with fewer subspecialty needs. So now we're at 4 subspecialists as opposed to 5. So we've gotten more patients pulled in because of that. But we're starting to see that there are some patients that are starting to age up a little bit. And with that, we have to address some of the lifespan considerations for some of our patients in terms of how do they transition care from their parents once they turn 18. How do we consider other elements of school-based supports that they were receiving that may end, or just their own life, employment, other things that become relevant for those patients. So we're starting to help develop that transition portion as well. A lot of our patients have G-tube needs. Probably 60% or so have some type of feeding support through something along those lines. Probably about 25% of our patients have ventilator needs or tracheostomies. And there's so much more than that as it relates to where else they come from. But those are some of the key numbers.
You mentioned you have a social worker, and I'm thinking, my kid had one ologist, and I'm a medical person, and I still felt very overwhelmed. Is that a big piece too, in addition to the care coordination and the care planning and all of that, like helping these families find resources in their community for all the things. Like, I think of some of these young moms that don't have a lot of support systems in place. Like, is that a big piece of
100%.
this also?
Yeah. Go ahead.
No, go ahead.
Oh, don't fight. Just both talk.
So yes, this has been a huge work that has been done, again, behind the scene by social worker and collaboration with schools and other community services. But I would like to mention how this program has not only empowered families to care for their own children, it has empowered families to support their peers in this medical group. So, for example, if you have somebody with certain syndrome, these families have been mentoring the younger one and helping them, sharing the needs and addressing that, whether it is on a platform here or, it's amazing how all of a sudden you're walking to a patient's room and all of a sudden they know each other and they know that, oh, so-and-so with this syndrome told me that we should be feeding this way and this route. So this has also been huge because some of the families have done the homework that maybe a social worker couldn't done it because of the lack of time and lack of resources, but they've paved the way for others or younger families. So that is, to me, that's like paying it forward, and I love it.
You gotta
teach someone to fish or whatever the saying is.
Yeah.
You're getting a complex care community that's kind of building itself.
Sure. That's it. Absolutely. It is a complex care community.
Well, and part of that is so many of our family caregivers that come into our program, the social workers aren't always just providing the resource needs. They're doing mental health checks as it relates to those family caregivers. And so they're trained formally in that. They provide that added resource. We're able to identify one of the key things that happens in the world of children with medical complexity is that family caregivers feel so much social isolationism that we may be some of their only adult interactions outside of their home, in 2 to 3 months. And so from that standpoint, it's important that we address those mental health concerns as well that may get missed in other visits. And so they're great at helping identify resources for that. And so it's great from that standpoint.
Okay, sir. So you are the director. You started as it, and you are it still. Mm-hmm. What is the future? What do you want for the future of this program? If you had your magic wand.
Sure. There's going to be, so we've been exclusively an outpatient program to this point. And I think part of our goal and our mission is to bring parts of our program to the inpatient side and to help develop those aspects of once a child that has medical complexity is in the hospital, they have their own unique set of circumstances and needs that hasn't necessarily been addressed by each individual medical team service that is in our hospital. And so from that standpoint, I think, and with working with Dr. Tanios, I think helping develop an inpatient program that can provide consultation, that can help in many of these ways with many of the same resources is going to be really important to build. I think we have a lot of national work that's being done on committees for these patients that relates to advocacy at the legislative level. You were talking about, the amount of time that's needed for a clinic visit. Well, so much of that is dependent on whether or not you're getting paid for services that you're providing versus the value that's gained from them. And so that's a trend in medical healthcare that is changing in some ways. So we advocate on that behalf. We advocate for these children if there's disability or other needs that aren't being met, gaining services for them to take part in fun, not just function, not just, some of the basics of their living, that they can thrive, that they can take part in school, that they can take part in activities, so on and so forth. So we're building that part. But I think one of the aspects that I'm really interested in is helping pull in parents and other family caregivers to the research process that we have in our program. And so much of what is driven in terms of our research projects that we try to help develop. Like, for instance, I'm trying to develop ways of having better agendas and even video monitoring of our care conferences that we have with families to really optimize those and get what's really needed out of those. We want to have a family caregiver that's involved in the project creation, in terms of helping through that dissemination of information, in terms of thinking through even becoming published themselves as it relates to something along those lines. So pulling in family caregivers into the research process for these patients, if they have the time and availability, that's something that I think we really take a lot of interest in. And so I would love to see that part of our program grow, and maybe even pull in a family caregiver to be a formal member of our team at some point. I think that could be something that we see in the near future.
Wow. I didn't even know y'all were doing research. See, I'm learning. I'm learning today. I have to be transparent. When I was doing my prep for this, because, I'm just not smart about things. So sometimes I have to do a little homework. Anyway, I was looking at both of your LinkedIn pages, and in doing so, Dr. Tanios, you have something fun on your LinkedIn page.
Do
and
I? What
you do. There's a quote. There's a quote on there, and it says, "Caring for pediatric patients is a privilege. Teaching future physicians is a mission. And being trusted to mentor others inside and outside the workforce is an honor. As a professional, the opportunities are never ending for self-growth, as well as supporting others reaching their full potentials." And I know it's good, isn't it? It's some good stuff. I know it's so good. And I just feel like that is what we are talking about here today. You are mentoring, you are taking opportunities, and you are not only showing other physicians how to care for patients, but you are helping families reach their full potential. You truly are. And I just want to thank both of you for your passion and for starting what you did and sharing about it here. You are the Glennon factor.
Oh,
you truly are.
And
we are so excited for our next segment. You are the first segment we are having 2 parts to, and I'm so excited about that. It's complex. It's so complex. We need 2 segments, right? But in our next segment, we are going to hear and see the actual impact from the Watson family, who you both know really, really well. Sweet Lavender was one of the first patients, I think, enrolled in the complex care program as a baby, and she's 7 now, which is exciting, right?
Yes,
so great.
I love Laffy.
And Dr. Tanios, you're going to stay with us for that next segment, and because you were their person. You were their first complex medical care physician. And then Dr. Smiley is going to join us as well, because he's Lavender's current complex care doc. So we'll hear the Watson's journey with complex care. And so we're going to take a short break and be back. Any final thoughts from either of you?
Well, you go.
No, I'm prepping.
Oh, here we go.
All right, let's rock, paper, scissors. Ready? Rock, paper, scissors, go.
No, I really want to thank you both for this opportunity. And it's really humbling to care for the children with medical complexity. It's empowering to learn from the families. And I can't say enough about these families. I think they taught us more than we did teach them. They may not think so, but they kept us grounded. And it's so humbling to see that they're coming for us for a certain rescue, when really it's them who are doing the job. And I say it all the time to them, I don't know how you're doing it. I can't do it. And I'm a mom of 4 kids. And I will freak out if I have to give, maybe not freak out, but I will get overwhelmed if I'm going to give my kid 2 medications, morning and evening, for 10 days. They do tons daily without skipping a beat. So talking about devotion, we have really the most admiration for the patients as well as their families.
Right. It's something that we take with honor, that we get so much insight into a family's life just in dealing with these chronic medical conditions. And so from that standpoint, we take it very seriously. We enjoy it. I think that there's a lot of positives with it. Certainly there's a lot of heartfelt stories as well. And we've been through those, but we have that as a team. We can embrace that as a team. We can really share some of our experiences with others. And I think that that's helpful too, just to really kind of at least paint a little bit of a picture of what some of these families are going for. So I really appreciate the opportunity to talk about that. And thank you for that.
Can I say one more thing?
No.
Thank you. You know I will. The bond we have with these families is so strong that we talked about kids graduating and outgrowing different specialties. We haven't mentioned the kids who are not with us anymore. And that takes a huge toll on us, on our emotional well-being. I can't tell you enough how they're part of our lives, and we get so attached to them. And I love that the family knows that. And this is why to say that we've been honored to be part of their short journey on earth, we really mean it.
Agreed.
And I love my angels. There's so many right now.
Yes.
They loved you too. Well, thank you both very, very much. We're
Thank you.
excited for part 2 to hear further affirmation of the awesomeness that you started and that continues.
Should
Thank
be
you
great.
both. Thank you.
Thank you.
We hope you enjoyed this episode of The Glennon Factor. Make sure you follow The Glennon Factor and leave us a review wherever you get your podcasts. Visit glennon.org if you would like to learn more about how you can support Cardinal Glennon kids. And while you're there, feel free to share any feedback or episode suggestions on our podcast page. The Glennon Factor is recorded and produced by SSM Health Cardinal Glennon Children's Foundation.